Somatic symptom and related disorders involve somatic or bodily symptoms to which there is an excessive or maladaptive response. In this video, 4 DSM diagnoses will be discussed: somatic symptom disorder, illness anxiety disorder, conversion disorder, and factitious disorder. Historically, the central feature of these somatic disorders was the presentation of somatic symptoms in the absence of a physical or organic pathology. The assumption was that the somatic symptoms were simply a manifestation of psychological disturbances, referred to as neuroses. Today, the only remaining diagnosis that carries this assumption is conversion disorder, which we'll get to in a little bit. First, let's begin with somatic symptom disorder. To be diagnosed with this disorder, an individual must present with at least one somatic symptom, although in most cases these individuals present with multiple symptoms. While the full list of potential somatic symptoms is nearly endless, some examples of possible somatic symptoms include migraine, heart palpitations or chest pain, knee pain, and gastrointestinal problems. The crucial criterion of this diagnosis involves how the individual responds to the somatic symptoms. Individuals diagnosed with this disorder will respond to the symptoms with persistent worry, behaviors, and/or feelings that are excessive and maladaptive. This might include disproportionate thoughts about the seriousness of the problems, high levels of anxiety about the symptoms, or excessive time and energy devoted to them, including repeated doctor's visits. Illness anxiety disorder, a new addition to the DSM-5 that serves as a replacement for hypochondriasis, is marked by a persistent preoccupation with being or getting seriously ill. For these individuals, as opposed to somatic symptom disorder, somatic symptoms are not present or they're very mild. Here, the preoccupation is directed at the potential for current or future illness, even though there are no current signs of illness. Often normal bodily symptoms, like heart rate, are misinterpreted as calamitous. The same goes for mild symptoms, like a sore throat from a common cold. Many individuals who meet the criteria for this diagnosis frequently seek medical attention for their concerns. They are referred to in the DSM as the care-seeking subtype. Others may actually avoid medical care due to the overwhelming fear of being ill, called the care avoidance subtype. With conversion disorder, also known as functional neurological symptom disorder, the individual is experiencing a motor or sensory malfunction in the absence of any physical or organic pathology. The motor or sensory malfunctions can include, but are not limited to, seizures, blindness, body tremors, paralysis, and mutism. Again, the crucial component to this diagnostic label is that these symptoms are occurring in the absence of a physical or organic cause, and thus, the assumption is that they are psychological in nature. Finally, we have factitious disorder. With this disorder, individuals intentionally feign symptoms of illness or injury. This might sound like malingering, when a person pretends to be sick or hurt for an obvious reward, like to get out of school or for a financial gain. But factitious disorder is different. Rather, with factitious disorder, the individual is intentionally feigning these symptoms in the absence of a clear reason or external rewards. Even further, in some cases, the individual may actually feign or artificially induce the symptoms in another person. This is most frequently seen with mothers imposing illness on her child. Once referred to as Munchausen syndrome by proxy, the current DSM label is factitious disorder imposed on another. So why would a person do this? It might be to play the sick role, or the parent of the sick child role, and possibly to gain the attention of others. But essential to this diagnosis is that the factors driving these behaviors are unclear.